This conference will now be recorded.
Okay, so welcome you all again to the Breech class. Now, a few important numbers from the external cephalic version guideline, and all numbers you people have to remember because question comes from every number. Okay, so successful ECV percentage is 50. Everybody knows it, and if they say success of ECV in primary gravida, so answer will change to 60%. And if they say successful ECV in multipara, then answer will change to 40%. Okay, so these are the percentages that you have to remember. Apart from this, spontaneous version from breech to cephalic in primary, okay, after 36 weeks, though it is very less, after 36 weeks that spontaneous version can happen by itself. Okay, by itself also breech can turn up into cephalic after 36 weeks of pregnancy in 8%. From this number also I have seen many questions. And after failed ECV, a spontaneous version can take place in 3 to 7%. Okay, so this is the scenario where they will give you a scenario that patient has come for ECV and you tried that, but it failed. Okay, and baby remained in breech. So you will, in that particular situation, when the version has failed, still baby can turn up into cephalic, and then percentage will change. That is 3 to 7. So you have to read question very well. If it is spontaneous version in primary after 36 weeks, it is 8%. But if it is spontaneous version after failed ECV, then answer will change to 3 to 7. Okay, so this is important. Apart from this, this number is real important because from where also I have seen questions. What is a reversion after successful ECV? Okay, so you have done ECV and patient baby is quite successful, but just before the delivery you find it is again breech. So this will happen in 3% of the cases. Okay, I will share this screenshot of this slide, and this is real important that from every number you will get question. Now what will be the number important from the breech guideline? So on what is the perinatal mortality? So these numbers you have to remember because question come from every number. So perinatal mortality, if the cesarean section is done after 39 weeks, so it is 0.5. Okay, it is for the general all kind of cesarean without having any like for any indication. Now coming to birth, if it is a planned breech vaginal birth, then perinatal mortality increases to 2 in 1000. That means it becomes 4 times from of the perinatal mortality if the cesarean section done after 39 weeks. From these numbers I have seen questions, so you have to remember this number. And this number is easy to remember. Planned cephalic birth, what will be the perinatal mortality rate? It will be 1 in 1000. So all numbers are important, and question usually comes from this number, that in planned vaginal breech birth, perinatal mortality rate is 4 times of the cesarean section if it is done after 39 weeks. Okay, then uh, if you have taken a patient for vaginal breech birth, but all the time it is not successful. Okay, so you will land up in emergency section. What is the percentage? 40. This percentage has to remembered by both part 2 and 3 people, because part 3 people has to explain this number to role player. Okay, when the role player station comes, then this number I have seen what will be the percentage of undiagnosed breech in labor. It will be 25%. Okay, this number also need to remembered by both 2 and 3 people, because undiagnosed breech is also a station for part 3, and you have to explain to role player that this is the number 1 in 4 baby can there could be possibility that we are diagnosing breech during labor only. Okay, so these two numbers are important for part 3 as well. Now, rate of head entrapment in preterm breech. Okay, remember this in the guideline. Entrapment rate has been given for preterm breech only, and it is 14%. Now, I have not seen any question from this number, but yeah, it is important number to remember as well. And what is the percentage of non-vertex twin at the time of delivery? This will be 40%. Okay, this is the number from where you can get questions from breach guideline. I will share the screenshot of this as well. Now, a few things here is important. Good questions are usually the questions are not coming from here, but few initial information is important. Why the breach occurs and what are the conditions? You know this. We have been reading from our MBBS days. So maternal condition, multiparity, because the tone of muscles is usually laxity is a problem. Congenital uterine anomalies we already know. Any space occupying lesion in the uterus, that is like the starting cavity, fibroid. CPD is one. Previous breech presentation is another one. Recurrent breech may happen. Placenta previa is commonly associated because lower segment baby has got no place for head to get engaged. Okay, so these are few maternal condition. Maybe sometime you will get some SBA from here. Then they will give you some conditions and you have to find out which condition it is not there. Okay, what are the fetal conditions? Most common is preterm, we already know that, and polyhydramnios and oligohydramnios both. So this is important to understand that even in polyhydramnios, it baby uh, can be breech, and also in oligohydramnios, multiple pregnancy malpresentation are real common. I would request all of you to mute yourself. And anomalies, we already know that in anencephaly and hydrocephalus, both the baby can be a breech baby. Okay, so this you have to at least know at one, not need to remember too much, because sometimes you will get one stem of SBA from here. Incidence of breech at 28 weeks of pregnancy is 20%. This number you may get in the question, and this number everybody knows. At that time it is 3 to 4%. Now, what are the type of breech? So frank breech or extended breech. So this is the extended breech, and this is the most common, because you may get question from here, what is the most common? So this is frank or extended breech. It will occur in 65% of the patients, and more common it will be in the primi gravida. So you have to remember only two words from here: complete breech or flex breech. It is least common. Okay, it is present only in 5 to 10%, and because of the laxity of abdomen, it is more common in multipara. Fine. Now, third is footlink breech. Footlink breech is present in 10 to 40%, and when the baby is preterm. Now, the common mistake will be done. People will think that footlink breech will be least common. Okay, but this is not true. Least common is complete breech, that is only 5 to 10%. So I'll repeat it again: frank breech 65%, complete is least 5 to 10%, footling is 10 to 40%. So this numbers you have to know. Now, why we are so much afraid of breech? We are afraid of breech because of its complication. So what can happen to mother? We already know. There could be trauma, tears, and PPH. What can happen to baby's head entrapment? We just saw the number. Baby neurological conditions can happen. Joint dislocation can happen. Fracture of the bones can happen, and cord prolapse. So this everybody knows, but you have to remember this number. This number is real important, and at least remember like like see it once, though it is not very difficult to remember. Frank breech, though it is more common, but cord prolapse is only 0.5%. Complete breech, it is 5%, And you cannot forget this in a Footlink breach. Footlink breach is a 15%. This number has to be remembered by part 3 people also, because Footlink breach is a station and you have to explain number of code prolapse to role player. And the source of this numbers is strategy. So please remember, minimum this one number has to be remembered. Footlink breach is 15%. Now, uh, breech delivery is important because for your clinical purpose also, part 2 also, and most important for part 3, because it is a teaching station. They will give you a dummy and doll, so props will be there, and you have to really explain this to the role player. And so you have to understand it, and then you have to practice it also, then only you will be able to do it in the exam. So there are certain basic principles. Okay, so too much handling of breech should not be there, and why it should not be there, that I'll be explaining later. And most of the effort in breech delivery is from mother. Okay, so because we want to do less of intervention, so there has to be good contractions and good maternal effort. Avoiding handling of the baby, fetal umbilical cord. Why? Because there will be vasospasm. Sacrum has to be anterior. Okay, always sacrum has to be kept anterior. uh, Only when like breech has descended up to pelvic floor, then till then the pushing has to be delayed. Even in the guideline also they have given, when active descent of the breech in active second stage of labor is only indication, so that you will go for, you will ask this mother to push more, or the delivery can happen. And if you think like breech has not descended, then even in the second stage also cesarean section can be considered. This you have to understand. This will be more understanding will come from the guideline, because you will get questions from there. Now, usually mother should not be put in lithotomy until fetal anus is visible. But according to the guideline, they are saying semi-recumbent and all four position. Okay, but for the practical purposes, what even the guideline says. So in whichever the position, the person who is delivering the patient is comfortable, patient should lie in that position. So for question purposes, you can, from the guideline, you can choose semi-recumbent and all four position. And you have to avoid traction all the time. So these are few basic principles. Okay, because that sometimes you will find this in a question, and part 3 people have to know this important, because your role player here, student, he will ask some of questions from here. Okay, now the breech delivery is of 3 types. So one will be spontaneous breech. So you are doing nothing, clinician is doing nothing, and baby is getting delivered. Another one, it could be complete breech extraction, where with complete baby is extracted with the clinician's hand. That usually only one indication we already know, that is a if it is a second baby in case of twin delivery. And third type of delivery is the assisted breech delivery. So what we are more interested is learning for the assisted breech delivery. So there are 3 types of breech delivery. So we'll be doing in explain for the assisted breech delivery only, because rest two usually what not asked in the exam. So whenever you are teaching your role player, you have to, patient safety is an important thing, and you have to keep always that in your head whenever you are explaining anything to your role player student. So was there has to have some prerequisite for the breech delivery. So what you have to rule out all contraindications, and what are the contraindication will be doing it from the guideline. So you have to find out that whatever the scenario has been given to you, and whatever your student role player is asking, so you need to find out whether I'm doing right thing, whether there had been any contraindication. Here I just want to tell you one thing. uh, in one of the like exam questions. So baby has a like a hyperextended neck, and the role player was showing putting the baby in hyperextended neck, and he wanted to learn breech delivery. So most of the people, they got confused and they explained breech, but that is against safety, because it was he was putting baby in a hyperextended neck position. So as a you have to find out that that is a contraindication, and you have to explain this to your role player. This is the contraindication for breech delivery. So this patient in this position has to be sent for cesarean section. So these are the catches. So this is one of the thing I just wanted to share because it happened in the exam. Therefore, you have to be very clear what the role player is asking. So it is patient safety. You have to rule out contraindications. Again, your mom should agree for it. Unless maternal consent, you cannot go ahead with the vaginal breech birth. Third, it has to be multidisciplinary approach. What that means, you have to have like a senior in the second stage of labor, at least a senior obstetrician should be there, who has like a complete expertise in doing breech vaginal birth. Along with that, like supporting staff, neonatal resuscitation things, pediatrician, and and the midwives all should be there. Okay, so it is usually multidisciplinary approach, and part 3 people have to explain this to their role play student also. Usually IV access is there. Why? Because anytime it may land up in section, anytime there could be tears or any wrong thing can happen. So usually there has to have an IV access. Bladder has to be empty. Everybody knows that. Episiotomy, even in breech delivery, it is selective. Okay, so you have to gain marks in part 3 station, you have to use this word selective. Okay, then only you will get marks, because this is their guideline words. So this is sort kind of buzzwords. Then when a breach, you usually allowed to descend spontaneously, and all the time in the breach you will do no traction. Okay, and baby has to be allowed to rotate spontaneously, and till that your hands, you will not touch baby. So this approach is called as hands off approach. So in your part 3 exam, just explaining few of the basics principle to your role player, and explaining complete prerequisite for assisted breech delivery using all buzzwords will give you marks. So this is real important for part 3 people. Now, so the delivery of the breech, it can be divided into 3 parts for the way of understanding. First, it will be delivery of lower limb and trunk. Then it will be delivery of shoulder. Then it will be followed by the after coming head of breech. Okay. So now, when the whatever the prerequisites just we read, when all prerequisites are there, and now baby is allowed to be about to deliver, then how we will deliver that baby. So first of all, it because basic principle is no traction, so it has to be maternal effort. So with the maternal effort, usually baby is allowed to expel by itself till the level of umbilicus. Okay, and and as you are not touching, doing anything at this level, so this approach is hands off approach. So for part 3 people, you have to explain this till the level of umbilicus. With the maternal efforts, baby has to come out, and this kind of approach is an hands off approach. So this is buzzword to give you mark. Then this is, you have to explain this to your role player. Excessive handling of a umbilical cord should not be done, because if it will result in vasospasm. And again, we are not touching baby too much. Why? it is again give you marks on patient safety, that if the too much of tactile stimulations or touching of the baby is done, then there will be reflex extension of arm or head. And if extension of arm will happen, then you will end up having baby in extended position or in the nuchal presentation, or delivery of head will become real difficult if the head becomes extended. So therefore they don't want to touch baby too much, and we should not. So it is that about the explanation of tactile stimulation. So part 3 people have in one line, they have to explain all safety point to their role player. Then now whenever, again this is again a safety point, whenever like uh, you have to do touch a baby, or you have to do maneuver, so you will hold baby around the pelvic girdle, not around the soft tissue. Why? Because injury to intra-abdominal organ may happen. So this is the femoro-pelvic grip, or holding the baby in around the pelvic girdle. So you can see, so you have to see this, and you have to put baby whenever you are reading in same position. So you can see two thumbs are parallel to the baby's spine, and these fingers are, you can put in the groin. So this is the, in this way you will hold the baby, and you will show this to your role player, that why I'm doing this, because we have to hold baby around the pelvic girdle, we so to avoid any kind of injury to the soft tissues. Okay, so you have to explain this, so this will give you marks on patient safety domain. Now so again this I have explained, but now you see hands are so I put this picture to show you hands off. So hands are away till the umbilicus is delivered, so they are waiting. Okay, so there had been a maternal effort, and they are waiting till the baby baby will deliver till the umbilicus. Now in this position, if baby's legs are flexed, so when baby is delivering by itself till umbilicus, legs will spontaneously deliver. Okay, so then this is the best thing, because we don't want to touch here anything. Fine. Now there could be another situation where legs are not flexed, but legs are extended. So what then you have to do something. What you will do uh, in that particular position, a hand could baby's leg should be followed till the popliteal fossa, and gentle pressure is given. Okay, so he is following baby's leg till the popliteal fossa, and with the two fingers, and the gentle pressure is given. With this there will be flexion, then and baby you and the person who is delivering will be able to hold baby's foot. Then the baby's foot will be once it comes in the hand of a clinician, so baby then it will be delivered. So this can be done. This will happen if the legs are extended. So similarly, another when the one leg is delivered, similarly another leg will be delivered. Okay, so in this way the delivery will happen if the legs are extended. There is an this maneuver have a name. Okay, but in strategy and in UK videos and in prompt manual, they have not mentioned the name of a maneuver. Therefore, I'm not speaking the name of this maneuver. This maneuver do have a name, okay, but it is not written in prompt manual, so I won't be speaking about that. Okay, though it is peanuts, fine. Now, this is a better visualization of this. Now, leg is extended, the clinician is putting the finger in the popliteal fossa. Now you can see that. So it will be a gentle pressure. So it will cause flexion. Then they will be able to like grasp the foot, and the baby's leg will be delivered. So this is a better pictorial presentation for this. Okay. So now baby is delivered till umbilicus along with the leg. So now this is the first part of the baby's delivery. Now, again, as we have to do, we never we want to touch very less, and everything has to be done by a mom. So again, we will wait. We will wait. So how long you will wait? You will wait till the tip of scapula or till the tip of anterior scapula will be visible. So you have to speak this to your role player. You know, in this particular situation, once the baby's leg till the baby's leg and the baby's body till umbilicus is delivered. After that, we have to just keep waiting till then you have to explain till when, till the tip of scapula is visible. So this is again a buzzword. Then when the tip of scapula become visible, now there will be two three situations. For the arm, if the arms are flexed, okay, so usually nothing will be required. With the maternal pushing only, they will deliver spontaneously, okay. And if some issues is coming up, then arm can be delivered just by hooking finger in the baby's elbow and flexing it over the chest. um, Arm can be delivered, and similarly it has to be done for the another other arm, okay. All the time we know baby has to be kept in the sacro anterior position. This line is from the guideline, okay, so from the our green top guideline. So this situation will, if the baby's arm in a flex position, and this is the easiest way. But there will be a trap when there had been a complication. So what complication can happen? Baby's now baby's arm can be in three position. So if one it could be flexed, another it could be extended, third it will be nuchal arm. So if it is a flex, then we are very happy. So we already know either it will come by itself, or you will or it can be released by hooking finger in the baby's elbow and just flexing it over the chest, and arm will deliver. And similarly for other shoulder also, same other arm will be delivered with the same maneuver. So this is the easiest thing, okay. Another situation will happen when baby's arm is extended, okay. So like baby's arm is complete this way, the baby's arm is extended. In that situation, what we have to do now, we have to do Loveset maneuver. So you all of you have to understand this Loveset maneuver, because it will be role player may ask this in the exam as well, okay. So first thing you have to understand that it is not a routine part of vaginal breech birth. Why it is not routine? Because it is for the extended arms only. It is not for the flexed arm. And vaginal breech birth, when we are conducting maximum time, okay, maximum time we will deal with the flexed arms only. So therefore, Loveset maneuver is not a routine part for the vaginal breech birth. Fine. So if arms are extended and if nuchal arm is there, then only Loveset maneuver is used. Okay. Whenever the Loveset maneuver, for performing the Loveset maneuver, baby has to be hold in a femoral pelvic grip. So where your thumbs will lie on the other side parallel to the fetal spine. I will explain. I will show that in a picture. Then baby will be rotated by keeping downward traction. Baby will rotate it 180-degree, so that posterior arm will become anterior. Then if with this rotation, and as the posterior arm will become anterior, so it will come below under the symphysis pubis. So then just by putting some pressure on the antecubital fossa or the elbow joint, arm will be delivered. Similarly, opposite baby will be rotated in opposite direction, and another arm will be delivered. So this is a theoretical part of it, but I will show you in a picture so as well. So this is this is picture from strategy. So baby, usually they are put this way, they are holding the baby in a femoropelvic grip, and they are rotating. So rotating, so in this way, to the 180 degree, okay, for to the complete uh, like 180 degrees. So if they rotate it to the 180 degrees, so this posterior arm, it will become anterior arm, and then uh, by hand will go above the baby's shoulder, and at the antecubital fossa they will just put their finger, so there will be flexion and the arm will be delivered. Now I will show you again in the picture. Now this picture is a better picture. So whenever the maneuvers are done, so you have to cover the baby. It is important because otherwise, if you do breech delivery, then you will understand baby's body, it is like covered with all this mecon, this liquor, and this vernix caseosa. So it is very slippery, so always baby has to be covered with a towel. So they are holding the baby in femoropelvic grip, then you in this way, keeping downward traction, they are rotating. So with the rotation, now the shoulder has come below the symphysis pubis. Okay, it is below the symphysis pubis, and this is the shoulder. Now what after, once this step has come after rotation, so then this is the second step. Index finger will be placed over baby's shoulder, and they will follow it till they reach antecubital fossa. Then they will flex the arm, and this way the delivery of arm will happen. In the then in this position, one arm is born. In the same way, they will rotate the baby again in 180 degrees. So this posterior arm will become anterior, and with the similar maneuver, this arm will get delivered. Okay, so this is the presentation for Loveset maneuver, and this you have to practice it on the mannequin, because maybe they will ask you in the exam. Okay, so this is all about Loveset's maneuver, and Loveset's maneuver is used for the extended arms, when the arms are extended. But there will be last type of situation. It occurs in 5% of the breach. This number is from prompt manual. So nuchal arm can occur in 5% of the breach. Okay, so this is the nuchal arm. So you can see it from the picture. Okay, so this is the nuchal arm. So if the nuchal arm is there, so again the rotation has to be done, and everything will be same as a um, as a like Loveset's maneuver, whatever we have discussed. But what will be the direction, what will be the direction, in which direction baby will be rotated? Usually baby will be rotated in the direction where the fingers are pointed. Okay, so baby's fingers are there pointing here, so rotation will be there. They have to rotate baby in this direction, then the arms will get delivered. So this much knowledge about nuchal arm is enough, because more than that they won't be asking just in the exam. This much is enough. Okay, so now so these are the three types of difficulty. Three things can happen in the arm: flexed arm, extended arm, and nuchal arm. And now we know how we will deliver it. Now this is the second part of breech delivery. Last comes the delivery of after coming like ahead of breech. Okay. So then you have to explain this to a role player. Now after the baby's arms are delivered, we have to support this baby, and further we have to wait. And what will be your waiting point? It is till the nape of neck is visible. And why we are doing this? Because this will help in flexion of the head and engagement of head in the pelvis. Okay, so this is again a important like landmark. and till the nape of neck is visible, you have to again wait. So all of these points you have to explain to your role player, like where and how much time, with the which landmark they have to wait till the further steps are taken. Now, there are three after for delivery of fetal head in Breech. There are three maneuvers are there that we have been reading from our UG days. So one maneuver is MSV, that is the Marcius Millienbit. Another one is Burn Marshall, and third one is the forceps. Okay, but in the new guideline, they have removed Burn Marshall. Okay, so for purpose of this exam, Burn Marshall we will not discuss because it has been like removed from the guideline. Again, in the exam also you have to, if it is a station is there, you have to say because of the safety issues, these days we are not doing Burn Marshall method. Okay, because maybe they want to check your knowledge in part 3 exam, you have to speak about that. Now I would be explaining MSV maneuver and also like forceps. Now why in MSV or maneuver, why it is done? Because it encourages flexion of the head. Okay, main thing whatever we want to do in the delivery of head, we want to encourage flexion. Why? Because this will help in engagement of the uh, shortest diameter in the maternal pelvis, then only the baby can come out. Okay, so and the baby is placed in position, and the name of this position is horse riding position. Okay, so where whole of the body of the baby is lying on the inner aspect of non-dominant arm, and two fingers of non-dominant, or you can say left arm also, they will placed over malar eminence of the baby, and dominant hand or your right hand will be on the upper side of the baby, where middle finger will be on fetal occiput. Why fetal occiput? Because it will help in promoting flexion, and your index and finger of both sides has to be on the fetal shoulders. Okay, uh, all of this will help in promoting flexion. Now I will, so this position is a horse riding position. You have to show to your role player and you have to learn it. So this is the horse riding position. Now this is the your uh, uh, hand below of the baby. So this is the position of two fingers. So two fingers are placed on the malar eminence, and this is the non-dominant hand or your left hand over the baby, and this is the position of three fingers. So one middle finger will be at the occiput, and two fingers, this is index finger and this is ring finger. So this finger they will be on the shoulders of the baby. Okay, so this is the position of hand for your like a non-dominant hand or left hand, or the hand that is lying above the baby's body, and this is the position of the hand that is lying below the baby, and this position is the horse riding position. This word is I have, this is from the strategy. Okay, this horse riding word is from strategy. So you can use this in the exam as well, and you have to show this to your role player, and you have to also explain to your role player that why we are doing it, because we want this will promote in the flexion. Okay, so these are the position of hand. Now they are delivering the baby. So if they're putting the babies in the horse riding position, and to further in this particular position, to further increase flexion, suprapubic pressure can also be given by your assistant. Okay, okay. I didn't put that picture of suprapubic pressure hand. I think I missed that. Okay, okay, so it is here. So this way, suprapubic pressure, this is the position of the hand while giving suprapubic pressure. Fine. you have to understand suprapubic pressure. We also learned in the shoulder dystocia, and direction of shoulder this suprapubic pressure in shoulder dystocia, it is from the side where the back of baby was there. So position of hand in both suprapubic pressure is different. For part 2 people, maybe it is not important, but part 3 it is important, because both of them can come as a teaching station, and you have to real know that where hand has to be put on the suprapubic pressure. It because all these small things, they carry mark, and in the exam we are tensed, so small simple mistakes can happen, so you have to be careful. Okay, so this way the suprapubic pressure is done. And then once you baby is kept in that position, and when the mom is having contraction, then whole fetus will be delivered along with the maternal contraction. So this is the MSV, or Marcius-Smiley and Witt maneuver. Okay, this is the position of the baby is holding, that I have explained you already. Now uh, again, another what we can do, we can apply the forcep for after coming head of the breech, and this number is from strategy. Maybe sometime you may be asked, 20% of the vaginal breech birth obstetric forceps may be required. Now, few things are different. Rest of the things are same as the cephalic presentation. So I would discuss that. So now whole baby's body is out. So what will be the different things? Baby has to be covered with a cloth. Okay, and you would require assistant. Your assistant will hold baby from and baby hold baby and gently lift the baby. Okay, so you can see this picture. Your assistant is gently lifting and supporting baby, and but have to be very gentle. uh, uh, tra- Undue traction or excessive traction should not happen, and forcep will be applied from below. Okay, so this way the forcep is applied. Okay, and how the application of forceps done? It is same as we do in the cephalic presentation, only this part is different. Then once the so it will forceps will be applied in the same manner. Then delivery of the baby has to be controlled and slow. So direct gentle, first there will be downward direction. Okay, downward direction, and when the baby's chin reaches perineum, then upward traction they will do. So um, this way will be the application of forceps, and this way it will be a direction of traction. So first it will be downwards, and once the baby's chin is visible, then it will be upwards. And whenever they are applying traction, by that time whole of the baby will lie over the blade of the forceps. Okay, then assistant has to leave baby that time. Okay, so when the forcep is being applied, like whenever the traction is given, that time baby will rest over the forcep handles. So this is the only difference that you have to know. That this is difficult. I never don't think so. They will a role player will ask this, but you should know this much is only important. Another important thing that you have to know, what kind of forcep you will apply. Type of forceps that is apply is the Piper forceps. So this is a picture of Piper forceps. You can see it is especially designed for vaginal breech birth only. And and this is the normal forceps, Wrigley forceps, what we are using in cephalic, um, uh, uh, when the cephalic presentation is there. So now I have put this picture for the comparison. So in Wrigley's forceps there is a curve. Okay, but in Piper forceps there is no curve. Okay, and you will use sometime get this question about Piper forcep. And also you have to know if in your hospital you want to deliver a baby, Piper forcep is not there, so what could be the second option? So second option will be key lens forcep. That will be instrument of choice. From this part you will get a number of questions. Maybe your role player may ask what kind of forcep we can apply and why. Okay, so now the baby's head is delivered. So this much I have to say about delivery of breech. So this is assisted breech delivery. So any one of you has not understood anything, so tell me, then I'll explain again. Any questions till now?
No, ma'am, it's clear.
Okay, so
Yes, clear.
okay, thanks. So I try to like make it very simplify, try to make it very simple as possible. And for part three, people please do this, like read it very well and practice it with the mannequin, because it is a commonly occurring teaching station. Okay, now few things are maybe you get question from here. So this is one of the complication. And what if the fetal head is entrapped? So what you will do? So these are the things that has to be done if the entrapment of fetal head is there. And like first of all you have to call for help. Second time, you can do McRoberts maneuver as per shoulder dystocia. Suprapubic pressure can be applied. MSV can be re-attempted in conjunction or in the help with the suprapubic pressure. Baby can be put in a sacrotransverse position. Consideration for tocolysis can be done. That will be 100 micrograms GTN. And consideration for surgical management, that will be symphysiotomy or it could be cesarean section. So this is copy pasted from strategy. It is nothing from my head or from anywhere, but you should know, because even it can be asked in the exam. Okay, so this is the management for fetal head entrapment. Now in the guide, this is not related to breech. Okay, like assisted breech birth we have already done, but this I just want to explain, because in the guideline one time you will find a word Braches maneuver. So just for explanation of that I had put this picture. So what is a Brache maneuver? It is not practice these days. Okay, just for explanation of guideline I have put this picture. So this is a Brache maneuver. So once the arms of the babies are delivered, baby is held from by the hip, uh, and baby baby is then lifted this way towards the mother's stomach without any traction. Okay, and in this way, like delivery of the baby used to happen. The consideration of suprapubic pressure can be done. So this is Bracht's maneuver. Just to explain that term in the guideline, I just put this slide. But this is not practice, so you need not to remember anything about that. Okay, so that's all about breach. So now I'll be moving to guideline. Till now, if any one of you have got any question, can ask me. Okay, no question, then it's fine. So now we'll be doing guideline. So
Ma'am,
so
hello.
yes, yes.
Ma'am, just one thing I'm having the doubt. In the first slide, you showed that the risk factors are the multi-parity. But here in the guideline, in the first page itself, they gave it's more common in the nulliparous. So which one has to be taken, ma'am? The
Repeat
first,
your question.
yeah, in the slide that you shown for the risk factors, you shown that the multiparity is the risk factor, but here in the guideline it is shown as the nulliparous, ma'am. More common in the nulliparous. So which one has to be taken? multiparous and nulliparous.
Okay, so yeah, in the slide, what so I have taken that from strategy. So if more common in nellipara, okay. So actually in the slides, what they have shown, if it is flexed, hyperextended, or frank breech is more common in nullipara, and if it is a complete breech, then it is more common in multipara. So if they are specifies the type of breech, so in that situation you can say frank is more common in nullipara, and flex complete breech or flexed breech is more common in multipara. But if they are not specifying you type of breech, they are just asking you uh, in which it is more common, then the answer will go to nullipara. So this way I will do.
Okay, ma'am.
Is it
Okay,
clear
ma'am.
now?
Thank you. Yeah, yeah. Thank you, ma'am. Thank you.
Is it recurrence high in nulliparous or
Yes,
common in nulliparous? It says the guidelines says recurrence risk is more common in nulliparous.
yes, recurrence
How can we
okay,
say that the
recurrence risk.
nulliparous recurrence? How can we say in the nulliparous that the recurrence risk? Nulliparous is the first one, no?
See, recurrence risk, according to my understanding, they are saying in congenital anomalies. So it will be associated with congenital anomalies as a recurrence risk. So significant recurrence risk will be in if the uterine anomaly is there, or okay, any septum or anything arcuate is there. Understand, it is not about they are not asking this recurrence in nulliparous or multiparous. Is it clear
Yes,
now?
ma'am. Yes, ma'am. Yes, ma'am.
Okay, so
Yes, ma'am.
I'll repeat it. If they give you frank breech, so answer will be more common in nullipara. If they give you complete or flexed breech, more common answer will be multipara. But if they give you breech uh, and give you nulli and multipara, then answer will be nullipara. And if they want to ask you recurrence risk, so recurrence risk will be more in if the uterine anomaly is there. That is understandable also. If any septum or anything arcuate uterus is there, so it is going to repeat. Okay, so recurrence risk will be more. Fine, so this is my understanding. Okay, so I would like to volunteer one person. So Madhu, you can come.
Yes, ma'am.
Yeah, so this number we have done, but what do you think, what is the incidence of breech presentation at term?
3 to 4%, ma'am.
Yes. Okay, so this is 3 to 4%. Okay, so this we know this is more important for part 3. So whenever the breach is there, and so usually when the patient come, so we have to like explain them options. So first option will be ECV. So we have to explain ECV risk and benefits to that patient. We have to explain them about planned vaginal breach, but you have to make it sure that all contraindications are ruled out. And third option we give them is a planned cesarean section. So these are the three options usually we will be giving. So now, if the planned cesarean section is there, so what is the benefit as compared to planned vaginal breech delivery? So what is the
There will,
benefit with a planned?
yes, ma'am. Yes, ma'am. Planned cesarean section, there will be small reduction in the perinatal mortality, ma'am, when compared to the planned vaginal
Yes.
breech.
So yes, so this you have to understand because you will get question from there. So we do section, cesarean section. Why? Because there will be a small reduction in perinatal mortality rate. This benefit is there. Okay. So and what are the three factors? If you do cesarean section, so what could be
Uh,
three benefit can be there?
yes, ma'am.
Why
There will be
reduce
avoidance.
mortality?
Yeah, yeah. Yes, ma'am.
Yes.
There will be avoidance of the stillbirth after the 39 weeks of the gestation, and there will be avoidance of the intrapartum risk, and also there will be the avoidance of the risk of the vaginal breech birth. These three will be there, ma'am. Because
Yes.
of these
So
three there will reduction in the risk because of all these three.
yes. Yes. So therefore therefore we plan cesarean section because cesarean section usually it is at 39 weeks, so that stillbirth rate will decrease. There will be no intrapartum problem will happen, and all complications of breech will not happen. Okay. This number we have done already. The perinatal mortality rate with the cesarean is 0.5. Planned vaginal birth is 2 per thousand, so it is 4 times. This we have discussed. And with the planned cephalic birth, perinatal mortality rate is 1 per thousand. This number you have to remember. Okay. So if the patient goes for planned vaginal birth, planned vaginal breech birth, so what will happen to baby?
There will be risk of the low Apgar scores, and there will be risk of the serious short-term complications. But for the
Yes.
long-term morbidity, there is no risk.
Yes, so this
It
part
is
also it is important. Whatever happen will be short term. Baby will be in ICU, Apgar score will be low, or any whatever the complication will happen, that will be short term. But long term, if the baby is delivered as a breech baby, there will be no problem. Okay, this is also important. Okay, elective cesarean section we are doing because it has effect on the perinatal mortality rate. It reduces that we already know. Okay, so this is the number. So if you are planning planned vaginal birth, how many number of women will land up emergency section?
40%.
Yes, this number is important. It will come in exam for both 2 and 3. So, and what if the like patient you're explaining about cesarean section, so you would explain about in future pregnancy what complication can happen if she goes for cesarean section.
There will be increased risk of complication of the repeat cesarean, and also there will be increased risk of the abnormally invasive placenta.
Yes. So you have to explain to your patient possibility of repeat section and placenta acarita previa will be there. Therefore, so either they can go for vaginal birth or they can go for cesarean section, but we have to give them complete information so that it is the patient who will decide. Okay. So in the subsequent pregnancy, uh, I have not seen question, but what they say there will be threefold rise in uterine scarring. If in first pregnancy planned section has happened, and if they want to go for future pregnancy, so there will be threefold increased risk of uterine scarring. I have not seen any question, but if they ask you what is the risk of in future pregnancy, what will be the risk of uterine scarring, so you have to give answer as threefold. Okay, so this number you can maybe you can get question from there. Okay, so this everyone knows this part. So what are the so if your patient is there, then you have to look for certain factor before agreeing for vaginal breech birth. So what are the independent contraindications for vaginal
Hyper,
breech birth.
yes, ma'am. Hyperextended neck on the ultrasound, high estimated fetal weight like more than 3.8 kg, low estimated weight that is less than 10th centile, Footlink presentation, and evidence of the antenatal fetal compromise.
Yes, so all of you have to learn this, both part 2 people and 3 people, because
Ma'am,
for
ma'am,
part
can I ask?
2 people, yes,
Can I ask one question, ma'am? Ma'am, if that is the less
yes, yes.
than 10th centile means how much kg it may be? Because in some of the questions it is given only in the kgs. So how can we know that it is less than 10th centile?
Yeah, you're right, and this is difficult question. Actually, this before 2017 guideline, it has
Yeah,
changed. This guideline has changed. Okay, so
okay.
in previous guideline before 2017, they have given low estimated weight as 2 kg.
2 kgs. Okay,
Okay.
ma'am. Okay.
Less than 2 kg delivery vaginal breech birth should not be allowed. But the question what you were seeing, it might be an old question. But after
Oh,
2007, if the question come, they will give you centile. They will give you in your question, baby has a fifth centile or sixth centile. Then you they will make some scenario, then you have to give an answer. So vaginal breech birth cannot be allowed.
yeah.
Okay,
Contract.
so
Okay.
this
Yes, ma'am.
will
Yes.
happen. Yeah, and someone has asked me question, can we do ECV breech in early labor? Yes, ECV can be done in early labor. Now, a few things are there. It has to be like less than three. It has to be 3 centimeter, or dilatation has to be 3 or 4 centimeter, and membrane should not be ruptured. Okay, and expertise should be there, and patient has to be explained in labor. Chances of success is for 50% only, but in the as she is in a labor, so chances of success doing ECV in early labor will be lesser than that 50% also. I think Rekha, I have answered your question. There is no role of pelvimetry. Okay, if you think that you will do ultrasound and you will just measure something, so role of pelvimetry is not clear. So this you have to understand. Okay, so they are always saying about this expertise. Vaginal breech birth can only be done if you have got skills, or skill birth attendant is there, or person with expertise is there. If it is not there, you have to refer this patient. So you may get question from there, this part also. Okay, now if the patient has come into the labor, and you find that there had been like a baby has come in breach. So what do you think, what factor should be there to allow for vaginal breech birth?
Uh, it depends on the stage of the labor and also availability of the appropriate clinical expertise and informed consent has to be there, ma'am.
Yes, so when we were discussing prerequisite for breach, so I just put consent also. So expertise
Yes.
has to be there. So these are prerequisite. Okay, so
Yeah.
stage of labor you have to know. Clinically, you will examine the patient. You will find out there is no contraindication. Expertise has to be there, and patient consent has to be there. Okay. So, if the patient is coming in the active first stage of labor, or in the first stage of labor, or active second stage of labor, routinely cesarean section should not be done. Okay. So this part you have to understand. Now if the patient has come, and you don't know, she's not carrying any ultrasound, so that you know what is the position of neck and leg, or you don't know about the what is the fetal weight, then if the facilities are there, then consideration of ultrasound can be done. If the time allows, like patient is in early labor, you can arrange for an ultrasound. then you can find out the baby's neck position and leg position. So and also the weight of the baby, because if it is hyperextended neck or it is a Footlink presentation, and if it has been a extremities of weight, then that you will not allow breech birth. Okay, so ultrasound can be done if the patient, if the possibility is there, and if the like facilities is also there. Because vaginal breech birth, if the expertise are also there, then only then also uh, you can allow this only when the all contraindications has been ruled out. Okay, so what is the breech presentation not diagnosed until labor? Or another question it can comes, what would be the percentage of undiagnosed breech in labor? So this number is important.
25%. Yeah,
Yes,
25%.
and everyone has to remember this number. Yeah, it is 25%. Now, what do you think about oxytocin? You usually get question about this also. So if the breech in labor, what is your understanding of giving oxytocin?
We cannot induce the labor. Induction of the
Hmm.
labor is not usually recommended, and augmentation with the oxytocin, if the contraction frequency is very low, then only we have to admit the this oxytocin. Otherwise, it is not indicated.
Okay,
Thus, too,
so
in
we
the
are
presence
not
of the
doing any,
epidural. Uh,
yeah.
yeah,
So we are not doing any induction in breech, okay? Because we just read that we are waiting for mother has to do maximum effort. We are not doing anything, okay? We want to do less intervention, so we will not augment, we will not do induction of labor. Second, we allow the labor to progress by itself. We will not put any oxytocin also. If the labor is progressing normally. But second situation, patient has got epidural. So if epidural is there, and if the contractions are less, this is a one indication where during breech delivery consideration for oxytocin augmentation can be done. This you have to understand, because you will get question from this line. Okay, so what vaginal epidural analgesia can be offered, but interventions will be likely to have more. Because why? Because contraction sometimes becomes less, so in that particular position delivery will become difficult, because in vaginal delivery more effort has to be done by mother. Okay, so what do you think about fetal monitoring in breech delivery?
it has to be continuous. No? Continuous electronic fetal monitoring has to be done
Yes,
because of the
and
because of the
why?
because of the increased risk of cord prolapse,
Cord prolapse and cord compression. So we are
compression.
worried about that. Yes, so therefore we want to keep eye on the baby. And on the other side, if the fetal, if baby is coming, if the fetal monitoring becomes abnormal, in breech there is no role for any blood sampling cannot be done from buttock. So if the in your scenario baby is getting breech delivery is happening, and ECG becomes suspicious pathological, only option is for cesarean delivery, because you won't be able to do any kind of fetal blood sampling. So you may get scenario from this also. Okay, so what is a like this we usually whenever the breech delivery is done, it is done in the hospital at the place where facilities for immediate cesarean section is there, because we have read a number 40% of the women will end up having a cesarean section. Okay, what do you think about water birth in breech?
It is not recommended, ma'am, due to lack of the gravity and also
Yes,
difficulty in any intervention is needed. Then it will be very difficult. So it is not
yes.
recommended.
Yeah, because in the breech, whatever we are doing, we don't want to do much of the intervention. So we want baby to deliver by itself. So baby has to hang, okay, and this will be from the gravity. For the gravity, like baby has to hang till the nape of neck is visible. So if the gravity is not there, so that engagement of fetal head will not happen. Therefore water birth is not allowed. Okay, what are the components for, though it is not that important, but you know also, what are the essential component of planned breech birth?
That will be the that case has to be selected like any no contraindications for the vaginal breach. So that is the case selection, and there will be strict protocol, and also availability of the skilled attendants has to be there. These three are the
Okay, this
essential
is again,
components.
yes. So these are the prerequisites for plain vaginal breath. No contraindication has to be ruled out. There has you have they have to follow protocol. Expertise has to be there. From this part, you will get a number of questions. So what is the prerequisite for active second stage of labor?
Uh, the breach has to be in the passive second stage, man. It has to be uh, come as on its own, like passive second stage. And it has to be there
Adequate.
has to be adequate descent has to be there.
Hmm. So if the baby is adequately descended in passive second stage of labor, so this is the one very important prerequisite, then only you will allow this mother to push. Otherwise, why you will push? Ask them to push. Okay. So adequate descent in passive second stage of labor is only one prerequisite to allow them for active pushing. Okay. Yeah, and if the progress is slow, even at this stage, cesarean section can be considered. And if the patient in this position also, if contraction is less than 4 in 10 minutes and patient is on epidural analgesia, we just read above also, consideration for oxytocin can be done, okay, in the second stage also. And if the breach is not visible in 2 hours of like adequate descent is not there, you are not able to you are not seeing this breach, and there had been 2 hours of passive second stage, you have to consider cesarean section. So all this, there are so many questions can come from here. So first, what is the prerequisite for pushing? That is adequate descent. Second, if the contractions are low and the patient less than 4 patient is on epidural, at this stage even consideration for oxytocin can be done. Third thing, if there had been 2 hours of second stage, okay, 2 hours patient is fully dilated and you are not able to see breach, please send this patient for cesarean section. So these three part you have to understand very well, because you will get question from there. And usually very easily ARM is not done in breach. It is reserved if there had been any clinical indication. Why? Because till the baby is in amniotic amniotic membrane is there, and if baby is inside the amniotic fluid, the chances of cord compression is less. So it is not that everywhere you will do ARM. In the breach, like you have to be reserved. So this part you have to understand very well, because you will get a number of scenarios and questions only from this part. Is it clear?
Yes, ma'am.
Okay, this part I have already explained. Now these guidelines say baby no, if the patient is not under epidural, contractions are not adequate, so Najma, we will not start any oxytocin, because if contractions are not coming by itself, and in that so there will be some indication of like cephalopelvic disproportion, some disproportion will be there. So usually oxytocin will not be given if if the patient is not under any epidural. Okay, I think I have answered your question. So position is semi recombinant in all four. So the I don't know how the delivery of breech will happen in all four, but what they say in all four, there is an increase in pelvic dimension. Okay, therefore they are saying this position. But I myself can't even imagine how the breech delivery can happen in all four. But for the sake of this guideline, you have to know that delivery can be in semi recombinant position or all four position. Okay. Okay, so use this part I have already told you. This is all about the breech delivery. So breech delivery we have done in so much details. Usually they're asking about assisted breech delivery. So assistance without traction. So this without traction, no traction is real important. Okay, so you will this is about the assisted breech delivery. Now this is about the hands off approach. So hands off approach I have explained it well. Usually hands off should be done till the baby delivered, till the body of baby, till the umbilicus has delivered. Okay, so till that you will not touch the baby, and this approach is a hand up of approach. But any time if like baby you find that baby there is a suspicion that extended neck, arm, or if any poor tone is there, in that particular position consideration for intervention can be done. Okay, the tactile stimulation will cause extension of arms and leg. This I have already explained. Again, baby has to be grasped from the pelvic bone, okay, girdle, not from soft tissue. Why? Because the injury will happen, that I have explained. And episiotomy is selective. So this part we have done it already. We have done it. This part you have to understand from here. So if there is more than 5 minute delay from buttock to head, or if there had been 3 minute delay from umbilicus to like head, if more than 3 minutes are there, in that particular situation, intervention has to be done. So you may get this question from here. Okay, 3 minute, 5 minute from buttock to head, and 3 minutes from umbilicus to head. If baby is not delivered within this time limits, you have to do some intervention. Now, how to do this is about the Loveset maneuver, suprapubic pressure. This part I have explained it very well in assisted breech delivery, so I'm not repeating it. Now, Burns Marshall is not advised, so you have to know why. Because if in Burns Marshall method, because the baby is to be, we used to hold baby with the leg, and baby has to be put in an arc of a circle, so overextension of baby's neck can happen. So this is the reason they are not promoting Burn Marshall. Okay, this is about the Brachts maneuver. So you, though the guideline, uh, it is they are not recommending this Brachts maneuver, but you have to know this Bracht maneuver. You may get questions, so I have shown you already before. Okay, so if the preterm breech is there, so in that particular situation, what do you think? What would be the mode of delivery in preterm breech?
It has to be individualized, ma'am. It is based on the stage of the labor and type of the breech presentation, and is there any fetal compromise, like fetal well-being is there or not, and for the availability of the operator, skilled operator for the vaginal breech delivery. So
Yeah,
this
so you
has to
will,
be there
so there,
according to that individualized. Yeah.
yeah, so if you find preterm baby, that too in a breech presentation, it is not any reason to rush for cesarean section. You will see stage of labor, you will do PV. You will look for contraindication, you will look for fetal compromise, and you will look for expertise. So it is overall management. Okay. Usually 22 weeks to 26 weeks is a threshold of viability. So routinely cesarean section is not done, because with this baby, survival of baby will be difficult. Fine. So what when planned cesarean section will done for the breech baby?
When there is any maternal or fetal compromise is there, then it is a cesarean section plan will be done, ma'am, in the preterm also.
Yes. So if section will only be done if there had been any indication. No, in breech, induction of labor is not done. No induction in breech. Okay, so if preterm breech is there and there had been a head entrapment, so how to manage head entrapment, that I have already explained. So, and it can happen in 14% of the deliveries. Okay, this also I have put in the slide. So where you will put incision, Duerson incision?
2 o'clock position, 6 o'clock position, and the 10 o'clock position. 2, 6, and 10 positions.
Yes,
The
you have to remember
Doherson
this.
transition.
Yes, because you will get question from there. Now, there is a if there had been a twin pregnancy and first baby is breech, so what will be your management?
Cesarean, ma'am.
Okay. No, but they are saying planned cesarean section
Yes, ma'am.
is
When the first
they have
twin is
put.
breached, then first twin is breached, so it is definitely the cesarean.
No, no, no.
Hmm?
See what they now. A woman should be informed that the evidence is limited. That planned section, if the present first baby is breech, okay. So like they are not saying that for every for a baby, if it first baby is breech, they will do cesarean section, because they do not have this evidence. So according to this line and according to this guideline, if first baby is breech, it is not an indication for cesarean section. But again in September 2000, I think last year September 2019, nice guideline for twin pregnancy has come, and in that guideline they have clearly said that if the first baby is breech, it is indication for cesarean section. So
Oh,
usually, yeah, in that guideline 2019 September guideline, they said that if the first baby in breech, it is indication for cesarean section. Now this has been a confusing situation. So according to this guideline of breech, they are not doing it routinely, but according to nice guideline, they are recommending it. So it is again difficult situation what to answer. But in this situation, latest thing should be, in my opinion, uh, what is the latest guideline that should be followed? Okay, it is a confuser.
so
In
nice
both,
has to be followed, ma'am. Nice is
yeah,
the
nice
decision.
has come
So
in 2000. Yeah, nice has come in 2019. So
okay, ma'am. So okay.
this is my opinion, because there is no guideline for that what to follow, but usually the latest thing has to be followed.
Okay, ma'am. Okay. Thank you.
Okay. And if the now you will get in scenario where the twin has come in labor and first baby in breech, so what you will do?
Ma'am, can you please repeat?
So yes, twin pregnancy, a twin patient has come in labor
If it is in the
So what
labor,
we
it
will
is
do?
not recommended. It is not recommended, ma'am. Routine emergency C-section is not recommended because she's already in the spontaneous labor.
Yes. Yes, in that particular situation, again, you will see the clinical condition of
Individual,
the patient.
yeah,
You will see for
yeah,
expertise. You will see for prerequisite. You will keep a whole picture in head.
yes, ma'am. Yes.
Okay, so what is the second twin non? What is the percentage of second non-vertex twin at the time of delivery? At the time of
40%.
delivery, how many? Yes, this number you have to
40,
remember.
40%.
Yes, 40%. Now, what this is a governance arrangement. You will not get question from there, but you should know. Actually, for there has to have a simulation training. There should be clear case selection. Okay, then only the outcome will be good. You have to find out which patient you will allow for birth. There should be expertise and there should be following of protocol or adherence to guidelines. So all these things, if are done, so chances of complication will be like less. Okay, so again, counseling of the patient has to be done. So this is breech delivery. Now we have to do ECV. This number we have done, so we are not doing it again. This number also we have done, so we are not doing it again. This number also we have explained. I have explained. So success of ECV for multi-para is okay. I think I have put wrong. So overall success for multi-para is more. It is 60%. For nullipara, it is 40%. I think in the slide I have put this number wrong. So this you have to remember. So overall success is 50%. But if they say it for multi-para, then it will be 60%. For nullipara, it will be 40%. Okay. So this number you have to remember. Then self spontaneous version is 8% of primary gravida after 36 weeks. This I have shown in the slide also. And after if the ECV has been unsuccessful, then also 3 to 7% of the baby will spontaneously turn. And if the ECV has been successful, 3% of the baby will turn back to breech. So these are the number I have put in the slide also, and that you have to know, because you will get question from all this number. Okay, and if the ECV is done also, baby has come back in the cephalic presentation, then also for those pregnancies, chances of cesarean section and instrumental delivery are high. Okay, so what are success will depend on which factors of ECV?
Yeah. Multiparity and the non-engagement of the breech, use of the tocolysis, palpable fetal head, and maternal weight is less than 65 kg, ma'am.
Less center localization.
Posterior
Okay.
placenta
Posterior placental
and
location and AFI is greater than
and
10.
yes. So this number you have, this all you have to remember, because you may get some question from this also. So what about tocolysis? It tocolysis, it improves the success rate. Okay, and usually regional anesthesia or spinal or epidural they are not giving. But if it fails, then second time if the patient is coming, consideration for if regional anesthesia can be done.
Please mute
So what?
Dr. Sania. Dr. Sania, please mute the mic.
Yeah, please mute yourself. Okay, so what are the tocolytics can be given?
Yes, ma'am. 250
What are
micrograms
the
of the
tocolytics
salbutamol. 250 micrograms of the
Mm-hmm.
salbutamol in 25 ml of the normal saline by slow IV, or 250 micrograms of the terbutaline subcutaneously.
Yes, so this you have to remember because you can get question from this also. In previous guideline, it was terbutaline 250 micrograms subcut, but now they have also added 250 micrograms salbutamol, that is into 25 mils of normal saline, and this is for IV injection. Okay, what are the content what are the contraindication for beta mimetics?
If there is any significant cardiac disease or hypertension,
Yes, and if so this
there is any
if the patient has, yes, so if if a patient already has any cardiac problem and hypertension, so you have to avoid, okay, because they have effect on the heart also. And what could be the complication? There could be flushing, tachycardia, tremor, palpitation, and occasional nausea. So you can get question from this also. So when the ECV will be offered in multipara,
multipare 37 weeks, 37 plus
right?
0 weeks,
Yes, or nullipara.
36 plus 0.
Yes, so this number you everybody knows. Okay, so somebody was asking this question. So intrapartum ECV may be considered provided membranes are not ruptured and no contraindications. Okay, so intrapartum ECV in early labor, if membranes are not ruptured, then it can be done if the expertise are there. Okay, so if the patient has previous cesarean section and baby is breech, will you offer ECV to that patient?
Only if it is the one cesarean delivery, there is no greater risk, ma'am. It can be offered.
Yes. So this is again, this is a change from the previous guideline. Previous guideline it was contraindication, but after in this guideline, after one cesarean section, ECV can be offered. Okay, so what are the contraindications where you will not offer ECV?
If there is any, first one, the absolute contraindication is the placenta previa majora or any placental abruption or severe preeclampsia or abnormal fetal Doppler or CTC, then any multiple pregnancy except after delivery of the first twin, ma'am. And when there is any rhesus isoimmunization, current or recent, that is less than 1 week of the vaginal bleeding, or any abnormal electronic fetal monitoring, and if there is any rupture of the membranes, ECV cannot be performed. And also one more is
Yes,
oligohydramnios or any hypertension is there. Then additional precaution has to be taken in them.
yes. So these are the reasons where ECV is contraindicated. Okay, so in the placenta previa, you will already do cesarean section in previa. Why you will go for cesarean section? Multiple pregnancy, it is so difficult. How you will do that? And if there had been RH isoimmunization, okay, in the, then also in that situation, and if there had been bleeding within a week, 7 days, you get question from this part. There had been a bleeding 7 days back. So in that particular situation, your answer will be no, of course, ECV contraindicated. And if baby is not doing well, why you will do ECV? Because there will be more distress to the baby, more chances of complication. And if rupture of membrane, it you cannot do that. Okay, so and if consent is not there, so you cannot do that. So these are the reasons where ECV is contraindicated, and you have to know this because you will get question, and you they will write down this contraindication, and you have to pick from them which uh, that whether you can do this ECV or not. Okay, and though if the liquor is less. So doing ECV will be difficult. How you will do it? But still, taking too much additional precaution in hypertension patient or in oligohydramnios, it can be tried. Okay. So what is the rate of emergency cesarean section if the ECV is done? This is very common question.
0.5%.
Yes, 0.5% or 1 in 200. And what is the indication?
90%
Why
are due to
cesarean
vaginal
section?
bleeding. 90% are due to vaginal bleeding or any
So
abnormal CTC.
yeah, so when you are doing ECV, either something has gone wrong, so bleeding will happen, or CTG will become abnormal. So these are the indications. This number you have to remember. Okay. So ECV is usually done by the expertise. Even they have dedicated ECV clinics also. And whenever the ECV is done, it has to be done under uh, like electric monitoring, and there could be possibility of fetal-maternal bleed. Consideration for NTD has to be done. Okay. So how many attempts you can do at a time for ECV?
No more than 4 attempts, ma'am. In the maximum of
Yes.
10 minutes overall.
Okay, yes. So time limit is 10 minutes and attempt limit is 4. So this you have to consider. Okay. So if now you were doing a ECV and there had been a bradycardia. So what you will do? There is a bradycardia for 3 minutes. So what you will do?
It is normal, ma'am. It can be happened. The transient less than 3 minutes of fetal bradycardia may be happened after the ECV. If it is not improving after the 6 minutes, then there will be prompt preparation for the category 1 cesarean section.
Yes, so if we see a nice guideline in the bottom, so if prolonged bradycardia is there, usually if there had been a prolonged bradycardia for 3 minutes, so this will be pathology. This will be CTG becomes pathological. So you will start for conservative measures. So all what they are doing after conservative measures, if within 9 minutes it is not improving, then category 1 cesarean section. Okay, so this is the same explanation of nice guideline. So it is bradycardia for 3 minutes plus 6 minutes more will make it 9 minutes. If within 9 minutes there is no improvement, category 1 cesarean section. You will get question from this part also. Entity part I have explained. It usually they have got a dedicated ECV clinics, and in those ECV clinic by trained practitioner it is done. Okay, it is not done by anyone because it is not that easy also. Okay, I don't know, I have not seen question, but I this is good. Possibility of breech presentation if you do clinical examination, okay, on your abdominal palpation. So what with what sensitivity you can diagnose breech on clinics by your hand?
70%.
Yes,
70%. Only 70.
70%. So that this number, like when I was underlining this guideline for you people, then I just found this, and it appears to me like a new knowledge. So I marked it. So with our hand, we can only diagnose 70% of the breach. That means with the clinical hand, we will miss 30%. Okay, this moxibustion usually it is this is non-ECV method that can be done at 30 to 35 weeks of pregnancy, but evidence is not there. Okay, what is this? This moxibustion, what is this? It is a kind of a Chinese herb. What they do, they burn it. So with this fume, they think that there would be some kind of fetal activity, and by itself baby will turn up into breech. Okay, but any evidence to support this is not there. So this is about moxibustion. Anyone, any question?
Ma'am, ECV, can it be done for the any type of the presentation of the breech,
Yes, yes,
like
yes.
complete
Can be
Footlink?
done. Yeah,
Okay,
contraindication is
okay,
there, it can be done. Anyone, any
okay.
question before I give you questions? No question. Okay, good. If there are no questions, so I will ask you. So what happens if we do cesarean section? We just read it now.
Reduction in the perinatal mortality for those delivered by the cesarean section.
Yes. So it is a reduction in the perinatal mortality, those delivered by cesarean section. So we just read that in a guideline. Yes, answer is this much only. These questions are from strategy.
Attempt to keep the sacrum anterior. No, no, no. That is,
Yes, what you're saying?
May
we have to
use
keep the
suprapubic pressure
sacrum
No,
anterior has to
to
be kept,
deliver the
right?
fetal head.
this,
may
read
use
the question.
suprapubic pressure to deliver the fetal head.
Yes, yes, yes,
Yes,
yes.
what you will do? Sacrum has to be kept
Sacrum,
anterior.
sacrum
This is wrong.
anterior, man. Sacrum anterior. Yeah, it is wrong.
Yes. So suprapubic pressure can be used, and I have shown you how to put
Yes, ma'am.
suprapubic
Yes, ma'am.
pressure.
deliver fetal head.
Why we put suprapubic pressure? Because it will help in flexion.
MRCOG similarly methods involve delivering baby by flexion by placing one finger in the baby mouth. Oh, baby mouth, two fingers.
No, ma'am. Upward traction should only be commenced when fetal chin has reached the perineum.
Yes, yes, the upper.
Yes, this is the answer, because you have to put downward traction till the chin. Once the chin is visible, you will change the direction of traction to upward. Okay, and there I have shown you the finger where the fingers are put. It will be on the both sides.
Yes,
And
etc.
this, so don't do mistake.
Ma'am, I have one doubt. Is there any difference between Morrissey Willis technique and modified technique, ma'am?
No, I have not. I have not seen that anywhere. I have read from strategy. I have seen few YouTube videos, and I have seen prompt manual. Okay, so
Okay,
this
ma'am.
much
Okay, ma'am.
I have done, but I have not found anything.
Okay, ma'am. Okay. Thank you, ma'am.
Consider rotating the baby to the sacrotransverse position, ma'am.
So
Yes.
Should be
should be
managed with
managed with a do the incision 3, 6, and 10. 10.
No,
no, not at 3, 6, and 9.
it is
No.
not three. No, this is not
Yes.
369. It is
Yes.
I
3, 6,
610. So this is wrong. So
3, 6,
answer is sacrotransverse.
9. Sector transfer. Yes. This is
Okay.
answer.
Now you read. You can read this again. Okay, rotate the baby to sacrotransverse position. Management of entrapment of head. So this is the answer. Consider rotating baby in sacrotransverse position.
Encourage
Consider
active
suprapubic
maternal
pressure.
pushing once she achieves full cervical dilatation.
No, pushing has to be
No,
done if
ma'am.
it is adequately
Consi
descended.
yes, ma'am. Consider suprapubic pressure, ma'am, to deliver the fetal head
Yes,
by
consider
flexion.
suprapubic pressure to
Yes,
deliver fetal head by flexion.
yes, consider fetal pressure, suprapubic pressure to deliver head by flexion because it causes promotion of flexion. Easy question, not difficult.
Hands off position, ma'am.
Yes, it is clear, hands off.
Hands of approach.
This is the question. And okay, and this is the options.
Question, please, ma'am. Options, ma'am.
Elective C-section.
Why C-section?
Offer
Offer
ECV
ECV.
at 37. Offer ECV at
Offer
Yes,
And
37.
ECV.
follow up after 1 week.
you can offer ECV, okay?
Offer ECV after
Yes,
36,
ma'am.
37 weeks. Yes.
Okay, this I have already put the answer also, so you can see the question and also answer. So this is a nullipara woman. So answer will be offer ECV after 36 weeks. Okay. So this is another question.
Ma'am, for ECV, we'll not do if it is Footlink presentation, no, ma'am.
No, ECV can be done. Footlink is not contraindication for ECV. We have just done ECV guideline, but we never found Footlink as a contraindication for ECV.
Ma'am, but in breech guidelines, indication of cesarean section, Footlink presentation is there, no, ma'am.
Yeah, there it is there. So if you have done ECV and for Footlink, and if it is still remains as Footlink, then you have to do cesarean section. So it is contraindication for cesarean section, not for ECV. Okay, so have you read the question? And these are the options.
Ma'am, B, allow vaginal breech delivery.
Yes, we wait 6 minutes more.
This is normal.
Yeah,
It was returned, ma'am. So allow vaginal breech delivery.
but allow vaginal breech.
Now,
She is not in labor at present.
not 11. So, madam, why can't be the L, madam? Follow up in 1 week in the antenatal clinic. This
But
is
why you want to do
normally,
follow-up?
but it is not in the labor, no, ma'am. It is just ECB. Oh, so it is not indicated.
This patient is not in labor. Okay, CTG has become normal. So, like right now, you have to do nothing. No, sir. So, what they want that no, there should be no emergency section today. So, these are the option. If you go for option, what you will put?
Yes, ma'am. Yes, ma'am.
G.
It is not indicated. Yeah.
Yes, only this, because this appears to be very confusing. Everyone will think of allow vaginal breech delivery, conduct vaginal breech delivery, but this patient is not in labor. So this is a catch here.
Yes, ma'am.
Okay, though it appears to be so simple, but if you don't understand the stem of question, silly mistake will happen. Okay, so this is again question. These are the
Category
options.
1 CS.
CS, ma'am. Emergency CS.
Emergency C.
Category 1 section.
Emergency
F.
cesarean section. F.
Yes, emergency cesarean section. And one of you was saying what? Category 1. So why you want to do it category 1? There is no maternal or fetal compromise. So
Because
is a
she is
cesarean.
already in labor.
So that is
Ma'am,
fine,
she
but she
has
is doing
history of
And she has
precipitate labor.
precipitate labor.
precipitate. Okay.
So she might deliver if you don't, do
Yes,
cesarean in 6:30 minutes.
yes, precipitate labor I never saw. Okay, fine. And these are the options.
Is it the category 2 cesarean, ma'am?
Category 2 CS.
Yes, category 2 cesarean.
Yes, answer is category 2. Category 2 cesarean section.
ECV.
Yes, ECV,
ECVN.
external cephalic version. These are now Justin Conji book's question. And these are the options.
Ma'am, question, please.
Options, ma'am.
D.
Yes. So this patient, like she has got previous 3.6. So that means her baby will be nearing that. Pregnancy is uncomplicated, 3 centimeter. So like no rush is there. You will allow vaginal breech delivery only when the prerequisites are uh, has been confirmed. For that, you have to know the position of baby's foot and neck. So please arrange for scan. So this is the answer: arrange position of neck and leg on the ultrasonography. Okay, so this is this question directly from the lines of guideline.
Options, ma'am. A, ma'am.
A.
Allow the breech to descend to the peritoneum.
C is better. Assess for fetal size. They have given baby size, all baby size. Okay. Previous was 3.8 and 3.75. Now if it is 3.8 only, then only it can be allowed. So because you don't know right now baby's delivery, baby's weight, so you have to assess for fetal size, fetal weight, then
Ma'am, but she's
9
but she's
centimeter.
9 centimeter dilated.
Yes, 9 centimeter dilated, but a both are creating problem. But if anyhow, if I have to choose between A and C, maybe I will mm, choose C, because at least they have mentioned something about weight. Okay,
Okay, ma'am.
so this is the question.
This will be A.
I think here A will suit, I think. Already ruptured and
C.
descending.
6 centimeters, head is engaged, membranes ruptured, complete breach. See, complete breach at spine. It has not
Yeah.
descend down.
Can't we allow the breech to descend down? Okay. For fetal dose.
Here, baby is only at spine. Okay, baby has not come down. So unless baby comes down, you cannot like promote her. And in the
Ma'am, why
like
can't
they
it
have
be
not.
D, ma'am?
Already it is
Why can't
the
it be?
D, because
D.
fetal, it is not still descended.
yeah. Why to choose the directly the emergencies? Yes, ma'am. Nothing
But
is
on
given.
admission, she's 6 had engaged. So this is
We can wait
undiagnosed
for the
breach.
descent. Can we wait for the descent in breach?
Like better answer would be like this is no, this is undiagnosed breach. So you can assess for this thing. As ideally, assessment of fetal size, position of baby has to be done. So D could be the answer, better answer. If the facility for ultrasound is there, assessment of position of neck and legs. So book answer is this cesarean section for fetal region, because this is undiagnosed breach. But in this particular situation, this appears to be better answer. D, you assess her first, because according to the guideline also, if the undiagnosed breach comes in labor, you have to do complete assessment to rule out all contraindication. Expertise has to be there, consent has to be there, then only breech delivery can be done. So I think D will be the better answer here. But this is the book answer. Okay.
Ma'am, for both primary and multi, this is the same.
Yes. According to the guideline, it is same. You have to assess.
Oh,
If the undiagnosed breech patient is coming in labor, you have to complete clinical picture you have to see. You have to rule out if there had been any contraindication to breech. You have to look whether expertise are there and maternal consent is there. When everything is there, all prerequisites fulfilled, then only cesarean vaginal breech tubing can be planned. Okay, and from
so
any
if
of
in
them,
exam, if in exam
in
they
the
don't
exam,
give all these prerequisites,
no, they will give you scenario where you will find that yeah, you can allow breech delivery or not. And if they want cesarean section, they will mention some contraindication. So you will be able to identify that from the exam. In exam,
okay,
exam is much
okay.
better than this book.
Thank you, ma'am.
So what you will do?
Delivery of arm.
Options, madam.
So delivery of arm they have not given. So what will be the maneuver for that?
What's it, ma'am?
Yes. So
Love
answer
sets,
has to
madam.
yes.
Loveset
Answer has to
maneuver.
be Loveset. So this is what you will do now. Arms
MSV.
are delivered. Yes. Answer has to be MSV. That is the method of choice. Okay. So this is the question.
Ma'am, one doubt in the last question for delivery of arms that mentioned as Loveset's maneuver, but it is like it's only for nuchal arm, no, ma'am?
Yes, but they have not given delivery about the delivery
Option.
of arm. Option is not there,
Okay,
so
okay.
you have to choose that. You know,
Okay, ma'am.
it is what is right and wrong. It is that what they have given you. Now, anything they have not given about arm, so you have to choose a love set. This is the question answer. These are the options.
Ma'am, question, please.
ECV at 36 weeks.
Uh, multi-para.
37 weeks.
She is
Multi.
multi-para.
37. Sorry, ma'am.
Okay,
Uh-huh.
so be careful in the exam. This small mistake can happen.
Electronic fetal monitoring.
Fetal monitoring.
Which is the answer? Tell me the answer.
Sorry, F monitoring on left
F.
side for
Continue
6
F,
months.
F,
monitoring on
ma'am.
left.
Yes, so answer is 6 minutes monitoring. Okay. Okay, this is the question. And these are the options.
Stop the ECV.
Stop ECV.
What is the answer from here? Answer is
Option A.
Abandon
yes,
ECV.
abandon ECV and schedule for elective CS. Okay, that's all.
Ma'am, if you're asking for elective CS, it can be at 39 weeks, ma'am.
Yeah, it can be 39 weeks.
Thank you, ma'am.
Okay. So
Thank you so
anyone of
much, madam.
Thanks a lot,
you,
ma'am.
okay.
It's very
Anyone of
useful session. Thank you.
okay.
Thank you, ma'am.
Anyone
Thank you so much.
Thank you so
anyone of
much.
you have